patients with heart failure and preserved ejection fraction, treatment with inorganic sodium nitrite does not enhance the benefits to exercise training. Hi, my name is Barry Borlaug. I'm a cardiologist and heart failure specialist at the Mayo Clinic in Rochester, Minnesota. And it's my pleasure to walk you through our original research article upcoming in the February issue of Mayo Clinic Proceedings, entitled Inorganic Nitrite to Amplify the Benefits and Tolerability of Exercise Training in Patients with Heart Failure and Preserved Ejection Fraction, the ENABLE Training Trial. This was a NIH-sponsored randomized double-blind placebo-controlled trial that was conducted at Mayo Clinic Rochester and also at 9 rural outreach centers in the Mayo Health System between 2016 and 2021. We know that heart failure with preserved ejection fraction has risen to become the most common form of heart failure in the United States and worldwide. And there are few effective treatments. But one effective treatment that is very simple and widely available is exercise training. Exercise training improves quality of life in patients with HFpEF, and it improves functional capacity. And this has been shown in a number of studies that were conducted mostly at large quaternary and tertiary medical centers. It's less well known how effective exercise training is in the real world setting, particularly in rural healthcare settings. Patients living in rural settings are underrepresented in clinical trials and have greater risk for adverse outcomes as compared to people living in urban settings. So this was one key feature. But we also know that the dose of exercise training matters, and people with heart failure are limited in their ability to engage in exercise training because of the very heart failure syndrome. The symptoms of breathlessness and fatigue with activity limit the ability to engage in higher levels of activity. So in this trial, we hypothesized that sodium nitrite, which is a drug that enhances nitric oxide production, and has been shown in other studies to favorably treat the hemodynamic abnormalities in HFpEF, would enhance the ability to tolerate exercise training by reducing the symptoms of breathlessness and fatigue, and allow patients to engage in a stronger rehab exercise training regimen and therefore gain greater benefits from training. So the study randomized a total of 92 patients. 73 completed the trial because of the loss of study drug availability. The trial was initially started using an inhaled formulation of nitrite. The company that produced that drug formulation stopped production of this and shuttered their program. So we needed to switch to an oral formulation. So the trial was completed with the oral formulation of the drug. Patients were typical of HFpEF. Most of them were older than 65 years of age, 80%. 3/4 of patients were obese, also very typical in the United States. And 63% of patients lived in rural settings. So looking at a more rural population than has been represented in prior trials. Overall training, which was administered over 12 weeks, 3 times a week, 36 sessions, resulted in an improvement in exercise capacity measured by peak oxygen consumption, and also improvements in quality of life measured by the Kansas City Cardiomyopathy Score, or the KCCQ score, along with improvements in 6-minute walk distance. So this was all very good. But contrary to our hypothesis, administration of nitrite during the training did not enhance the benefits as compared to placebo across any of the primary and secondary outcomes that we looked at. The primary endpoint was the change in peak oxygen consumption, which is the gold standard measure of cardiorespiratory fitness. And nitrite did not lead to a greater benefit in exercise capacity beyond placebo, though training itself did improve exercise capacity. So in the end, we conclude that adding nitrite onto conventional therapy with exercise training had no advantage. But we do see that training itself, we confirm prior studies showing that it's effective. And importantly, that it's also effective even in a real world, non-tertiary, predominantly rural healthcare setting. This is important for our patients because many or most patients don't have access to these highly specialized centers where they can undergo cardiac rehabilitation and exercise training. The negative finding is also important because it can steer us towards other possibilities, other treatments that might be effective in this regard to enhance the benefits from exercise training. One notable observation was that the magnitude of benefit in peak exercise ability or peak VO2 was relatively modest, 0.8 mils per kilogram per minute. Prior studies have shown benefits that were about 2 to 3-fold larger than this, again, in more specialized settings, sometimes with longer durations of exercise training. But even though we observed a relatively modest improvement in peak exercise capacity, this was associated with much more impressive improvements in quality of life, which is arguably one of the most important, if not the most important from the patient's perspective, and measurements of submaximal exercise capacity, 6-minute walk distance, which is more tightly correlated with patient-reported outcomes and quality of life. So this tells us that even modest gains in maximal exercise ability can lead to very impressive improvements in patient-centric outcomes and quality of life, which are frankly better than most of the medical therapies, pharmacologic therapies that we currently have available. So this really reinforces the importance of getting all of our patients with heart failure and preserved ejection fraction into exercise training programs, and stressing the importance of maintaining high levels of activity in everyday life to hold on to these. I think in terms of future directions, we have not shut the door on the possibility of using medical therapies to enhance the benefits of training. And there are a whole host of different candidate drugs which could be tested in this perspective. We also observed in this study that there was no significant reduction in body weight. And as I mentioned earlier, 3/4 of patients were obese. And recent studies, particularly the HFpEF trial published in the New England Journal, showed that weight loss induced by the GLP-1 receptor agonist semaglutide led to significant improvements in quality of life and exercise function. So perhaps combining exercise training with pharmacologic weight loss strategies can lead to synergistic benefits, and that bears further study in the future, as both of these have been shown to be very effective. So that summarizes our paper and the future research directions, and I invite you all to read our paper, and thank you very much for the opportunity to present it to you today.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.